And really thank you all for being here today. And it is really my privilege, my honor, a pleasure to be part of this program. Um, when I was asked by the Pheochromocytoma Alliance to give a topic on systemic therapies for Pheochromocytoma Paragangliomas that are metastatic, I said this is a really difficult topic. Because of course, the purpose here is not really to talk about technicisms, words that are very complicated, guidelines. I believe that guidelines are important, but we have to be careful with guidelines as well. And the reason why I mention this is because at the end, whatever we offer to patients is really what we see in the patient and something that somewhat connects us with the guidelines. But it's your decision as a clinician in coordination with the individual who has a Pheochromocytoma Paraganglioma, how we have to proceed. And at the end, I think that everybody is different, and we have to individualize how we evaluate the patient, how we treat the individual, and how we proceed with whatever plan of care we may have for that particular person. So with that in mind, what I have decided to do was just to start with an outline to tell you from a scientific perspective what our goals of systemic therapies are, and then to give you what I believe are tales of hope. Because whatever you see online is sometimes quite negative, or I would say not sometimes, very often negative. And I believe that we may be able to do things for many individuals who have pheochromocytomas and paragangliomas that are not necessarily curable by surgery. So the outline of the presentation will talk about the goals of systemic therapies. And what are the goals of systemic therapies? Number one, to cure if we can. But I will be realistic. Currently, we are not able to cure majority of patients. We would like to find treatments that are able to get rid of any tumors that the patients may have. And I think we are in the right pathway, but we need to work more. Number two, to stabilize the disease and to prevent a further spread. That I think is quite important. That will give reassurance, positivity, and the opportunity to the individual to continue living her or his life in a positive way. Number three, to prolong survival. Why not? To have opportunities to enjoy more of life, to do better things, people who like to travel, to go places, to see how wonderful the world may be, to continue doing art, to talk, to see the family growing. So that's very important. The next one, to manage the symptoms and to prevent complications, that's also very important here. And of course, a very one that is quite important to improve the quality of life, which is important and not limited to the improvement of symptoms of hormonal excess and tumor burden, as well as to face an acceptable toxicity related to any potential medication. So I'm going to just tell you about some stories of hope related to 3 patients. I was given 12 minutes to talk about this. So I'm just going to describe these 3 individuals who have contributed to our knowledge in the field. Number one, let's talk about a 26-year-old man who presented with a very difficult to control high blood pressure. The patient had palpitations, the panic attacks, constipation, throbbing headaches, and sweats, which are the classical symptoms associated to catecholamine excess, as all of you know. The patient also complained of abdominal pain. He underwent evaluations in a different institution to the one that I work. He had a CT scan. He was found with a large pheochromocytoma of 10 centimeters in size, and the biochemical studies confirmed that it was a tumor able to produce adrenaline and noradrenaline, the classical hormones. The patient was treated with alpha and beta blockers. His doctor said, well, we may do surgery, therefore we may be able to cure you. And of course, that's the hope of any surgical procedure. The surgery went well. He didn't have any complications. The symptoms disappeared. He underwent generic counseling, and he was normal in generic counseling, and he had some follow-up. 6 months after surgery, he was feeling really well. 6 years later, the symptoms of adrenaline and noradrenaline excess came back. So he had again the panic attacks, the high blood pressure. He had the palpitations and the headaches, the sweats, They were overwhelming. And at the same time, he was complaining of back pain. He had pain in his shoulder. And when he underwent radiographic studies, he was found with metastatic disease in different places. This is a CT scan of the chest. These are the lungs. The lungs are in black. The heart is in the middle. And when you look at the arrow, it is telling us that there is a nodule that is metastatic, together with others that are related to a metastatic pheochromocytoma. And when you look at the body scan, yes, there were some metastatic lesions in different parts of the skeleton. The patient was started on treatment with alpha and beta blockers, classical medications. The blood pressure was difficult to control. Then he was prescribed with nifedipine, but the blood pressure continued to be very difficult to control. He was frequently admitted to the emergency rooms wherever he lived because of hypertensive crisis and because of bone pain. The disease was progressive, the symptoms were intense, and in that particular time, he had an MIBG scan that demonstrated that the metastases expressed the noradrenaline transporter. And what is the noradrenaline transporter? It's one of the targets that we have in medicine for pheochromocytomas and paragangliomas. It's a complicated protein that some of them will express in the cell membranes. And whenever they have it, medications that are labeled with radioactivity, in other words, medications that carry radioactivity, may target that receptor, may go inside the cell, and may release the radioactivity, killing the cell from inside to outside. Well, there was a clinical trial at that particular time, a clinical trial with one medication that we call high specific activity, iodine 131 MIBG. It has a commercial name. The name is Acedra. This one became the first medication ever approved by the FDA. The patient didn't participate in the initial clinical trial, but there was an opportunity later to get that medication. And in order to do it, he underwent an MIBG scan. And the one that you see in the left side is what he had, MIBG uptake. Those black dots imply that the tumor had MIBG uptake. Then the treatment was provided. And of course, the treatment was given in a dose that was much higher. Therefore, the tumors light up even more. So they were more intense in that particular time. The treatment was provided. He tolerated the treatment very well. He felt some fatigue for maybe 5 days. He was admitted to the hospital to receive the treatment, but his bone marrow function, which is one of the concerns that we have with medications like this, was very well preserved. And what I mean by that is that radiopharmaceuticals may cause bone marrow suppression. In other words, they may lead to anemia, which is a reduction in the red blood cells, the cells that are responsible for the oxygen transportation, leukopenia, which is a reduction of the white blood cells that are responsible for protecting us from infections, and the platelets, which are important for the coagulation process. What happened to him is quite interesting. The lesions decreased a little bit in size, not really that much, but the bone pain disappeared, the blood pressure normalized, the antihypertensive discontinued, and the metanephins, the markers of catecholamines, almost normalized over time. And that happened about 90 years ago, and this is what to me is more important whenever I see it. Yes, when he presented with the pheochromocytoma, he was a resident in a particular specialty of medicine. So he was a medical doctor. It was very difficult for him to continue with his studies because he was frequently admitted to the hospital, to the emergency rooms because of the bone pain and the symptoms that he had for catecholamine excess. The treatment was provided. He was able to continue with a subspecialty, what we call a fellowship. And he finished in a very successful way. Then he became faculty in a very important academic institution in the Northeast. Then he got married. He has 2 children. He does cardiovascular and weight-bearing exercise, and he looks very, very good. He's very positive, and at this time, he does not think of pheochromocytoma or paraganglioma any longer, and he asked for his clinical follow-ups to be spaced from 1 year to 1.5 years because he feels fine. So what is the point here? This is an individual who was told that he was going to die. It's been now 9 years since when that happened. This is a study that was published then after. And who is he in this study? He's located in the upper part. 9 years, and he continues with a normal life. He asked me, am I cured? I said, I cannot really say that because we see the tumors in some way. However, the disease is quite stable, it's not giving him any symptoms. I want to believe and I hope that he's cured. Is this something that we have seen in cancer medicine in other conditions? Yes. For instance, in the context of immunotherapy, when we use it for people with melanomas, many times you see patients with melanomas in whom the tumors, after successful immunotherapy, remain quiet for a long, long period of time. Are they cured? Some oncologists believe that they are cured. Again, I cannot say that, but it's been now 9 years of a successful life, and I hope it continues like that. So this is an interesting tale of hope. Now, the medication was discontinued from clinical practice. Several factors were behind that, and I'm not going to discuss those. The only thing I can tell you is that it was not because of toxicity. It was not because of a safety issue. There were logistical aspects, misleading scientific information, and others that prevent the use of this medication, but hopefully a medication like this or someone else, something that is similar, may be developed someday to have an impact like the one that we see in some patients. I have to be honest, not everybody, as you can see here, will respond like that, but there were some individuals who did. Now, let me tell you another tale of hope. This is a 43-year-old man who had abdominal pain. The abdominal CT scan that he obtained because of the pain showed a 12-centimeter paraganglioma. His blood pressure was normal. He didn't have any symptoms of catecholamine excess. He underwent surgical resection, and he had a genetic testing once he was confirmed to have a paraganglioma, and indeed he had a mutation, a pathogenic variant of the SDHB gene. In other words, he has a paraganglioma syndrome type 4. He was told that he was cured, but in reality, on follow-up 1 year later, he was found again with abdominal discomfort. He underwent evaluation and he was found with multiple abdominal nodules. One of them, the largest one, measured 3 centimeters in size. The patient was evaluated with a DOTA-tape PET scan, and this test demonstrated an increased uptake of DOTA-tape. In other words, the tumor has a high expression of receptors for somatostatin. And then we said, okay, this is a patient who may benefit from a medication that we call Lutathera. And the patient was treated with Lutathera. Yes, the nodules continue stable for some time. And this is the treatment that he got. But only the stability lasted for 7 months. 7 months later, the disease progressed again. And what it was quite interesting is how the progression presented. The patient complained of severe abdominal pain, abdominal distension, difficulty breathing, especially when he was lying down in his back. He was not able to lie down in his back. And the CT scan showed many things that look aggressive. And of course, I don't pretend to analyze this, but to give you an idea, what you see in the left side in panels A and B with the arrows, if you look at panel B, you see many, many, many different nodules that were confluent, located in the abdominal cavity and associated with some liquid production, ascites. This is quite unusual. And when you see that, you say this is very, very aggressive. And people say, what can we do for this patient? Someone who exploded like that after a treatment that we thought was going to be effective, at least for some time. So we decided to provide him with chemotherapy. And why chemotherapy? Because it's fast. People say chemotherapy is difficult. Chemotherapy is full of toxicity. Chemotherapy is not an easy medication to tolerate. As we say, this is our best opportunity to do it. And yes, he accepted. He was reluctant, but he accepted because he believed on whatever we have to say. And yes, he started, and I'm sorry, I'm going back. He started the therapy. And after receiving the treatment with chemotherapy, look at panel D. Many of those lesions decreased in size. They disappeared. The liquid went away, and he was feeling fine. He only had a little bit of nausea. He had a little bit of fatigue with the chemotherapy. So he didn't tolerate the chemotherapy really badly. He was able to do well with it. And what you see here impressive is that the disease responded very well to therapy. Now, Can he continue chemotherapy forever? No, we discussed about that. And this is something that happened this year. And to give you an idea, on May 14 of this year, belzutifan was approved by the FDA. I cannot give you any information on the results of the belzutifan clinical trial simply because I have a confidentiality agreement. The results will be published in 4 weeks. It's going to be on October 18 at 10:30 a.m. There will be a presentation in Berlin, Germany. It's an oral presentation in the European Society of Medical Oncology meeting, which is now considered the most important oncology meeting in the world. They are given the opportunity to talk about a rare disease, and the publication on these results will happen at the same time. So we are close to that time. It's at that time that when we are going to hear about belzutifan. But because we are familiar with belzutifan, when he asked us, should I continue with chemotherapy? We said, no, we have a new option. And because the medication was approved, we gave him belzutifan, and he feels very, very good. He's not in the trial. It was with the medication approved after that. And he simply says, I'm happy because there is a plan to continue. And finally, to give you another tale of hope. This is an interesting one from a perspective of patients. Cabozantinib. Cabozantinib is a very interesting medication. It has not been approved for the treatment of pheochromocytomas and paragangliomas, and I don't expect that because in reality, the information is derived from a principal investigator, single institution, single arm clinical trial. The clinical trial is called the NATALY trial. And the trial demonstrated that cabozantinib could have a lot of activity in many patients who have pheochromocytomas and paragangliomas. And what I mean by that is simply that the tumors can get control and decrease in size. And if you have good clinicians helping you with the symptoms, you may have a good tolerability of the medication and you may improve your quality of life. What is more important to me is the name of the clinical trial, NATALY. Who was Natalie? Natalie was 30 years of age when she was diagnosed with a progressive paraganglioma that was associated with a paraganglioma syndrome type 4, an SBHP mutation. She presented with shortness of breath to an emergency room, and she was found with a very big tumor located in the chest, and she had to be admitted to the intensive care unit, and she required ventilation. While in the intensive care unit, she received chemotherapy because of how aggressive it was, and she responded very well. She recovered. She was discharged from the intensive care unit. She continued on chemotherapy, different from the previous patient. The tolerability to chemotherapy was a little bit more complicated. The tumor was MIBG avid. She received treatment with conventional MIBG, and she was stable for 3 to 4 years, and she traveled the world, and she was sending postcards from wherever she was. But she learned that her disease was not curable. And she said, I'm going to do something for people like me. So she created, together with her friends, what we call the TeamNat Foundation to raise funding for the development of clinical trials for patients with the disease. While waiting for the activation of the NATALY trial, she developed a complication related to chemotherapy, to MIBG, and I didn't tell you, she also got Lutathera, and she did not respond to Lutathera. And the combination of the 3 medications likely led to a bone marrow dysplasia, which is something like a leukemia type of cancer in the bone marrow. And the contributing factor to that was also the presence of tumor in the skeleton. She was treated with cabozantinib off-label, and for 1 year, she didn't require transfusions, which were common to her before, and she was feeling fine. However, her bone marrow insufficiency progressed, and she, at the end, passed away. What it was important here is simply that the medication was prescribed off-label, it was given to her in some way that was important, and she was able to bring something as a patient to the community. This clinical trial is unique because it's a clinical trial sponsored by a patient and her family. That's unique in clinical sciences. This is part of her legacy, and she and her friends exemplify courage, perseverance, resilience, and generosity. So with that in mind, I just want to let you know that when we talk about medical therapies, we have to individualize the patient. And as we discussed before, please keep your hopes. A new medication is coming forward. A new medication that was approved by the FDA in 4 months. Why the FDA approved a medication in 4 months. Why they were so impressed with those results, something that you will see in 4 weeks. So the future of people with Pheochromocytoma Paraganglioma, I think, is brighter than ever. And with that in mind, I finished the presentation. I'm from the University of Texas, MD Anderson Cancer Center at your service.